Thank you so much for coming.
Thanks so much for coming in,
It's
guys.
so helpful to have all of your perspectives tonight. So, Tim, over to you with the questions.
Well, good evening, everyone. I think it would be great to start if you could just introduce yourselves and maybe tell us a little about your areas of expertise, and then we can just start with the questions after that. So if we could start with the order on the screen. So if we could start with you, Filippo, is that okay?
Yes, of course. So my name is Filippo Passetti. I'm a consultant psychiatrist. I'm a general adult psychiatrist. Wouldn't describe myself as an ADHD expert in particular, but this is quite a substantial chunk of what I do on, as my bread and butter.
Okay.
General adult psychiatrist.
Thank you.
Thank you so much, Filippo. And if we go to Amber, could you introduce yourself, please?
Hi there. Happy Halloween to everyone. So I'm Amber Sadiq. I'm a consultant psychiatrist, but I specialize in children and families. And I work in the NHS, but I also work in private practice where I run a clinic where we very much look at kind of family mental health and neurodivergence. And so it's a real passion of mine to be here actually and talking about ADHD. So thanks for asking me.
It's an absolute pleasure to have you. Thank you so much. And if we could go to Mate next, is that okay?
Hi, good afternoon or good evening, everyone. So my name is Maite Ferrin. I'm consultant adult psychiatrist and child adolescent psychiatrist. And I've been working on the ADHD field for more than 20 years now. I work in the NHS. I also work privately. And I do research on ADHD. I've been part of the European Guidelines Group for over, almost 20 years now. So very excited to participate in this webinar tonight.
Thank you so much. It's excellent to have you.
Thank you.
Thank you. And lastly, Jack, if you could just quickly introduce yourself, please.
Yeah, hello. My name is Jack Krzysztofiak. I'm based in Jersey, Channel Islands. So I run private practice here, mostly ADHD related. Also do a TMS for the depressed patients. I've been in private practice altogether. I lived in South Africa for a long time and had a private practice there as well as a general adult psychiatrist. So thank you very much for inviting me to this panel.
It's a pleasure to have you too, Jack. So if we start off today's webinar, we've as it's mostly going to be addressing adult ADHD and ADHD in the workplace, but there will be some more general questions as well. So the first question is, I'm sure something you've all dealt with recently is a rise in adult diagnosis. Is this something you've noticed very much yourselves? If I could go first to Dr. Filippo, please.
Or whoever wants to answer as well.
Because
there's a lot of questions.
There will be a huge amount.
Whoever would like to answer the questions, go for it. Yeah.
Yes, the short answer is yes. I think my colleagues on the panel, I think will all agree. And I think it's a combination of a number of factors. So there's certainly a greater awareness, as your question suggested. But there are other factors too. So firstly, there is a more and more pressure on everyone to process more and more information on a day-to-day basis. And also since COVID, there is also more pressure on our capacity to organize our time. So I certainly have noticed for the first time this expansion in requests of assessments for ADHD when we all started to work from home, and suddenly there was no queuing the start and the end of the day, and people were required to do this themselves, to do this internally rather than having it as an external imposed routine. The final point that I think is still being debated is how the emphasis on working with screens and all these apps and other things that are competing for our attention all the time might have affected us. I think the question is still debated, and we'll probably know more precisely the answers to that question in a few years. But I think it's fair to say that we are all now, for the past 5 or 10 years, we have been part of a global experiment to which none of us has consented.
This is very, absolutely agree there. I'd absolutely agree there. Is there anything anyone else like to add on the rise of adult ADHD diagnosis?
I mean, I can jump in just because I work with children and families. So,
Yeah.
you know, for many years, we saw ADHD as a kind of childhood neurotype condition that, you know, in CAM services for many years, we were seeing lots of children, families where, you know, the child was kind of very hyperactive or impulsive, and we would assess and we would diagnose. And that's, I suppose, the kind of very stereotyped way of seeing ADHD. And as Filippo said, you know, we've kind of expanded our awareness over the years. In kind of the 2000s and with DSM-5, you know, we're really recognizing that adults have ADHD as well. Those children go on to become adults. And, you know, 2/3 or a little bit more than that still have symptoms which impact them. So I think that's really interesting, because we've ended up seeing adults struggling with anxiety, perfectionism, burnout, not coping with structures within the workplace. You know, if we're really thinking about kind of workplaces, and then kind of thinking, actually, why are we feeling like this? And I think with that awareness then comes the question around, well, could I have ADHD, or could there be something else going on? And I think we now we're not there yet, but there's more permission to seek that information, to have those assessments, which I think is quite helpful.
100%, absolutely. Well, one of the things I've always thought odd is that, as you say, in the past, ADHD was considered to be almost a children's condition, but I have no idea how it was ever thought that condition would simply go away. It would seem odd that if it is a neurological condition, then it would ever be suspected to just disappear.
Absolutely. Yeah. I think so. Sorry,
carry on. Sir.
Yeah. I think it's that focus on the neurological, isn't it? And it's the focus on actually. I think, you know, historically ADHD has been kind of clumped in with other mental health diagnoses.
Okay.
And I think we're now developing, and got colleagues here who I'm sure will talk to this, just developing more of an understanding around the neurobiology behind ADHD and the overlaps between ADHD and other neurodivergent conditions as well, which I think is, again, what a shift in our knowledge and understanding, you know, just over a short period of time.
Absolutely. Is there anything?
I think Jack's.
Yeah, just wanted to add that, you know, despite all this awareness, you know, we still have a massive disparity between recognition in children and adults, and there's still massive number of adults that are either undiagnosed, and even if they diagnose, they reluctantly treated or not treated. And on the point where the ADHD in adults hasn't been recognized in the UK, I think until 2005, as you said, so you have a whole massive group of medical professionals like GPs and specialists who are not aware of or have not been trained during their training on ADHD, so they're quite reluctant to recognize it, and there's a certain degree of resistance to accept the need for treatment. But nevertheless, I mean, there is certainly a greater recognition. I think I just attended another conference before this, and there was a paper saying that there has been a raise of 18% of prescriptions for ADHD since COVID. So certainly COVID has made a difference.
Seems to have made a massive difference.
So definitely there's much more recognition there. Yeah.
It's fascinating that you were saying, Amber, but it did seem in the past that it was seen as a mental health condition, which seems as an odd way to perceive ADHD, but it's good. It's interesting that the shift has changed that.
Yeah, we're definitely, I think, just understanding a lot more. There's still so much about the brain and the mind and the body that we don't understand. And I think even the connection between neurodevelopmental conditions, neurotypes, and then physical manifestations of neurodivergence, you know, kind of the bendy bodies that, you know, Jessica Eccles is looking at. And, you know, I think there's still, you know, where we are right now, if we were to have this conversation in 5 years or 10 years, I think we'll be having a very different conversation, you know, but I think it's a good start, isn't it?
Absolutely. And Filippo, you.
Yes, so you were asking how come people thought that this would suddenly disappear?
Yeah.
Well, the idea was that this was a disorder caused by a delayed maturation of the frontal lobes, and this would happen at some point. And most people would recover, and you know, some of it is definitely true, because not everyone who has childhood ADHD goes on to have adult ADHD. We have to recognize that. But the other reason why I think there are these issues with the recognition of the meaning of the diagnosis and the acceptance of having this problem is a misunderstanding. You know, it's more subtle, and it's about the meaning of diagnosis in psychiatry. In fact, you know, for across specialties, really, but particularly in psychiatry. So in psychiatry, a diagnosis is a model. So it's a way of predicting something. For example, comorbidity or response to medication. It's not a real thing. You know, everyone who, if you take 100 people who have ADHD, there are probably 100 different history and combinations of genetic, developmental factors and environmental factors. And you can't, you know, it's a simplification to say that they all have ADHD. It is, as I said, a tool. It's a model. It's a way of predicting things. You know, otherwise, a model is not a model. It's just a description, and it's completely useless.
Okay. Mate Farron, you have
yeah. So
I'm so sorry.
Add on what my colleagues are saying. You know, as adult psychiatrist, I used to see my own colleagues diagnosing people with depression, with other mental health disorders or conditions that were apparently more serious or severe. And then they were diagnosing these people, as I call it, transversally or transactionally, not instead of longitudinally. Okay, so they were saying, well, this person has bipolar disorder, this person has depression or anxiety. And that was it. And some of them would struggle to try and find out the reasons why this adult would end up in having this depression. And so I think then when I converted into child and adolescent psychiatrist, I could see, you know, some adult psychiatrists are missing the whole kind of neurodevelopmental and the whole history from childhood to adulthood. And it's such an important thing. They don't, and I think that was the issue of why previously ADHD in adults wasn't like properly recognized and properly. And I think probably adult psychiatrists are now more able to see the importance of the early years. Okay. And then the other thing I wanted to say is like a month ago, I was in a conference, and a colleague of mine from Germany, he said something that was very, for me, that was very, how to say, revealed the whole kind of picture of ADHD, which I think he said ADHD is a chronic or might be a chronic condition with which is waxing and waning, and it's getting worse when the situation and the circumstances are worse in terms of more difficulties, more challenging times, is when the symptoms get worse or get more visible, right? And we know that also about ADHD in women and how hormones are playing this very important role, okay? So I think it's about considering ADHD as a longitudinal thing, and then considering its symptoms shaping and becoming more or less important depending on how challenging the situation is.
Yeah, that aligns with the ADCA. David Gewerk spoke yesterday, and very much always, emphasizing, ADHD, it's situationally variable, like exactly what you're saying.
Yeah.
That's interesting. So did you want to?
I mean, I was only going to ask from probably more than an outsider's perspective. What is from a profession of psychiatry? How would you define ADHD? What would your clinical definition be?
So DSM-5.
Would it be that definition, or is there?
I think psychiatrists, you've obviously to assess. You follow. There's the DSM-5. There's also there's a European version.
Yes, we would, but this just serves for or helps with common understanding and communication between us, and unfortunately, that's a requirement to justify treatment in many ways. And when patients are transferred, you need that sort of communication tool and common language to really to communicate that. But it's by all means it's man-made. Like Filippo said, it's a concept, it's a construct, it's man-made construct, and it is fluid, it changes. So your DSM criteria, DSM-3 or so, might have been, they were different to what they are now. So, and we recognize the different aspects of ADHD and different presentation, and probably in the future we will probably include more symptoms into the diagnosis. So it is a bit rigid in some ways, but I think it depends on expertise where you can include all those other symptoms and nuances that patients present with, and then create a picture. So it's not so much more about diagnosis on one side. It's more about understanding the symptoms that person struggles with and they cause impairment of function, and then try to help them with the symptoms, because ultimately we treat symptoms, we don't treat the diagnosis. So, if somebody has more problems with hyperactivity or impulsivity, then we focus on that rather than, or emotional dysregulation, in a course of ADHD, then, there will be a focus on that in terms of treatment, rather than necessarily just all the three sort of DSM major criteria for ADHD. So, yeah.
Okay. Well, I mean, it's always interesting to know, because I think a lot of people might be interested to know from that clinical perspective what that definition is. Maite, did you have anything else to add there?
Yeah, just to follow on what Jack is saying. So we as psychiatrists, we have to follow DSM-5 criteria. We cannot.
I'm sorry, Maite, you just frozen there.
The young person or the adult need that treatment, right?
Yeah.
However, I think there's a tendency to over-focus on DSM criteria too much, and at times we're just like a bit obsessed with ticking the boxes of the DSM-4. DSM-5, and DSM-5 is just a guide, and we have to read between the lines, read the symptoms, why the symptoms show like that. I think it's more about just ticking.
Is there anything you'd like to add there?
Yeah, I'll keep it really brief because I know we've got lots of questions. I think it really does come down, and I think Jack and Maite have kind of alluded to this. It is around really strong clinical assessment. It's about that human assessment, about really trying to understand the different kind of aspects of that human being's presentation, the intersectional bits, because ADHD does change, like we've heard, over time. If we look at it kind of developmentally, a 6-year-old with ADHD versus a 12-year-old versus an 18-year-old versus a 40-year-old, and in that, gender plays a part, hormones, other life stressors. So it's about really, really, I do have a bit of a challenge with these kind of tick box assessments, I must say. But then again, we have such a huge challenge on our hands because there's many people who are not diagnosed and not receiving the support, especially in the workplace and in their life. So it's about finding that balance, isn't it? But DSM-5, yes, we do follow that, but it is really about having the expertise and the sensitivity around being able to conduct a very human assessment and not just the label, really thinking, what's the formulation here? What's the story here? How is this person going to understand who they are? Are they going to benefit from this? As doctors, our whole thing is about doing no harm. So it's actually about benefiting that human being in front of us with that assessment process.
Is there anything you'd like to consider?
No, I think that's, very encouraging to hear.
Absolutely.
And that's why you're our referral partner psychiatrist. Exactly that. Yeah.
I mean, going on to the workplace, when you encounter clients or patients who are struggling in the workplace and they have ADHD, what are the common struggles you encounter there? Is anyone who'd like to start off with that question?
Yeah, at what point do they come to you at? I mean, I kind of know the answer to this, but what point do you see them?
I think this is coming up in the questions, but I think the most common presentation is some form of burnout, stroke, other stress-related disorder, be this depression or generalized anxiety disorder or panic disorder. There are many reasons why people with ADHD might find themselves in those predicaments. People who are familiar with those descriptions of masking, which is not a psychiatric term, but I think it describes very well that propensity of many people who have these difficulties to try and pretend that this is not happening or assume that this is about their laziness and incapacity to get the job done. But at some point, all these comes to takes a psychological toll, and at some point, all this comes to a head.
Absolutely. Is there anything you'd like to add from state coaching?
Yeah. Do you find that, so would you say most of the people that you see, they kind of come to you before they've kind of gone on sick leave? Like, how often do you maybe have to actually encourage these ADHDers to stop and, take a break? Because, I'll be really interested actually in that answer. How often do you have to encourage them to stop and take care of themselves?
You're on mute. Just so you're aware, I have actually skipped a couple of questions because we've got
time.
the time issue. So if we do get the chance, we'll come back to them. So we've just gone on to the workplace questions now.
Hang on, Jack, was there something?
Yeah, so I think obviously one way of escaping pressure and burnout would be taking a sick leave, and but that often doesn't really help, because then they are in a very unstructured environment at home and mopping around and not knowing what to do with themselves. So I generally wouldn't really advise it unless it's absolutely necessary. I think often patients come with the awareness already. I think you've got a history usually of patients who change jobs frequently, and eventually they become aware of the fact that they come to a certain point in their career and suddenly there's a change of career, or they resign, or they're being fired and they have to start again. Usually there's some kind of conflict at work, usually interpersonal with the supervisor or the colleagues, and they struggle with their work environment. They struggle with being hypersensitive. There's often sensitivity to noise or work environment, and with current recognition in general population, I think the patients start looking for reasons why they underachieve. So my patients come often not necessarily in crisis. They come more because they've been through crises one after the other, and then are looking for answers. So and that's probably majority of my patients, that present with that. But there are definitely problems with underperformance, imposter syndrome, feeling guilty about not performing, and it's not only at work. It's the same thing happens at home. So they kind of failing and struggling throughout, and of course. If they have a very good awareness of what's going on, then that has emotional impact on their well-being. Yeah.
Yes, thank you very much, Amber. If there's something you wanted to add to that.
Yeah, absolutely. It's really interesting. So I see the other side because I work with kind of in my private practice, kind of high performing families. That's what I call them. And I come from a very neurospicy family myself. And so I can really kind of see, in my patients, I'm like, wow, you're working extra hard here. And there is really that risk of burnout. I'm really kind of seeing it in these very professional parents, professional adults, almost like, that masking, the hyper maskers. I know this isn't a very psychiatric term, but from what sorry, colleagues. But, it's those people that are kind of, really, I think that feel very ashamed of the fact that they do struggle with, executive functioning difficulties, task initiation, completion, task blindness. They know that there's a challenge there. They haven't quite got a word for it. They've maybe been told that they're lazy or they're not working hard enough. Then they've overcompensated for that, or they've put some strategies in place. Because often they're very bright. A lot of the people that I see in private practice, the families are very, very bright. But then when I see the kids or I see the kind of older siblings or the young adults, the parents then are like, oh, actually, hold on a minute. The apple doesn't fall far from the tree, and this is a highly heritable neurotype, right? So then the parents, the adults are thinking, actually, wait a minute, this is us, and we're burning out, or we're struggling, or we're hyper performing. And so it's really interesting, just listening to Jack and thinking, I probably see some of those families just before the adults, just before they kind of hit that burnout as well.
Filippo.
Yes, so it occurs to me another factor is blaming something else that you have come to recognize as a factor. And a case in point is women particularly who are particularly sensitive to the changes in sex hormones around menses. They've come to recognize that around those times they are more likely to crumble psychologically, to crumble under pressure. And of course, that is a factor, but it's coming on top of something else that is underneath, and it's running throughout their life, not just at those phases.
That's why we do have a lot of women that come to ADHD coaching. It's that late diagnosis. So premenopause, menopause, when they realize, hang on. Yeah.
What are the what do you recommend when you have a client who is struggling at work? What's your general recommendations for them? I mean, obviously it works on a case by case basis, but what would you recommend them to do, or how to cope?
So I must say I tend not to suggest an ADHD assessment in someone who has clear depressive symptoms or symptoms of a generalized anxiety disorder until that is under control. And this is because or an addictive disorder, for example. That's another area in which this comes a lot, because I think there are reciprocal confounds. So an assessment can be confounded by those elements being present, but also I don't want them to lose track of the other issue, take, for example, addiction, I want them to first look at the mechanisms, the antecedents of their addictive behavior before they start focusing on these other problems, which are longer term.
Is there anything anyone else wanted to add to if they have a client who has ADHD, what the general approach there if they are struggling in the workplaces?
I think from my point of view, working with adults who are within a kind of family context, and we do see adults for assessments as well, I think the self-disclosure part's really personal. As to whether people want to disclose in a workplace, that's really, really challenging. And I think I read a number that's about 78% of people with ADHD do not disclose within a workplace in the UK. And I thought that's quite high, but not surprising. So if someone you think, that you see doesn't have a diagnosis, I think just knowing that there might be some impairments or challenges there where they can put some reasonable adjustments in place. And sometimes it's putting them in yourself or speak, if you don't want to kind of say that you've got the diagnosis, but actually if you know that you're somebody that works better in a certain environment or working from home or wearing headphones because you're sensitive to noise. I think when you know yourself, you start to put some systems in place for yourself, which can be really, really helpful. If you've got a diagnosis, then really it's about, do you want to disclose or not, around that, and what support are you going to get in your workplace? Is your workplace somewhere that you feel safe to disclose in? Do you have a really supportive supervisor? So when I work in my NHS context, I've had many doctors who have come in and said, we have XYZ, we have this challenge. And it's really about then, maybe thinking about health passport, thinking about access to work. So I think there's lots of things that we can share with our patients, which we do. Then it's up to the patient, that human being, to then make an informed decision around what they want to do with it. But I think one of the best things, other than I think medication can be so helpful and unfortunately not accessible to everyone, through the NHS right to choose or through other private providers. I think coaching and just knowing yourself. And there's so much valuable information there. I think there's almost too much noise. So it is about being able to identify, for me as a psychiatrist, saying, have you looked at this website? Here's some really great podcasts to listen to. Have you read this book on ADHD coaching strategies? Using your website, for example, and I often refer people to your website and say, look, have a look at the YouTube channel. There's some fantastic resources on there, because some of the strategies are so simple, aren't they? Like body doubling, accountability partners. It's like little things that can actually really help that human being in the workplace.
Yeah.
Absolutely. Did this anything you'd like to?
Yeah, no, we always say, anything that an ADHD is struggling to do, put a body at the end of it, because we can do things for others we can't do for ourselves to help them get out of their own way. Yeah, ADHD coaching is fantastic for that. And as you said, everyone's unique though. What we've found, and like you said, ADHD is usually, they love to learn and they overwhelm themselves with information, right? Or they'll read something and the light bulb will go off and, oh my God, that will change my life, everything. Then they get distracted, outside of mind is gone. It's really, and that's so frustrating for them. So I think, for them getting to understand their own unique brand of ADHD and accepting their specific needs, that's something that the education, reading about, it's not going to get them there like a coaching would, for instance, in terms of how that process really kind of helps them have that evidence, unique to them that, oh yeah, this is what I do. Oh yeah, this is something that's always going to happen. Oh yeah, I'm not going to be able to do that. So I'm going to adjust that person's expectations and say to them, look, if you want that thing done, I would do it like this, or, get such and such to do it, because it's just not my wheelhouse. So I just tend to not prioritize these things. It's about that adjusting expectations that we've found as coaches, it makes all the difference. Yeah.
Absolutely. Is there anything anyone else wanted to add to that at all?
Yeah, I think just the educational part of it is quite important. The validation itself, it's so incredibly important. When patients receive the diagnosis and it validates what they always thought there was something going on, they couldn't put a finger on it, and now they know what it is. So that in itself helps a lot, and it then enables them to access other help. So they either will then choose to talk to their employers. I generally send an adjustment letter for work, so if they want to present it to HR, to their employer, that helps. I agree, not many people really want to disclose it. It probably depends very much on their relationship with their employer. Access to work scheme, I think that works very well, and they can access funding for coaching, and that usually is what I advise. So there are avenues, but I think education part, just a psychoeducation, and know what's going on actually, and resources on web which are available are extremely valuable. And then the lifestyle change that comes with it as well. We're a little bit rusty. We're not really trained to advise those sort of strategies, but like exercise, we know that helps. Microbiome is important. Eating, maybe fasting, maybe temperature. The cold dips and saunas and that sort of thing. All those things actually come together. They're quite important, and one needs a kind of more holistic approach to advice. And because we train the way we trained, we're all kind of in little compartments, and we experts in one field but don't know much about the other. And all of those are really quite important to manage those patients and help them.
I think it's fascinating that you mentioned a holistic approach, because as you say, different parts, different approaches have their own place to play, like therapy, like the coaching, and obviously psychiatry itself all have a role to play.
Yeah.
Did you have anything to add to that, Stephanie?
Oh, we interviewed a therapist we work with, Ruth Dine. So that, if you haven't seen that, that's a really interesting one to watch as well, in terms of the therapy, for ADHDs and how that plays with the coaching, and then obviously the psychiatry. But yeah, it's that whole team around the ADHD that's needed, isn't it?
Absolutely, yeah.
Yeah.
And just going back to something you mentioned, Filippo, you mentioned, so if someone does come to you, say with a depression, or say they an addictive disorder.
I realize I didn't finish the thought. I meant to say that I would say let's get you better first, at least on a more stable platform, and then if you're still struggling to with attention, self-organization, all those hallmarks of ADHD, then we can look at those. That's what I meant. Sorry.
Okay. Well, it's interesting because obviously ADHD and addiction obviously do have a very big crossover. So it's quite sometimes quite hard to separate those two. Is that true, or is that something which is?
I mean, like what you were saying before, Filippo, with my dad's a GP, and he's got a specific joke about psychiatry in terms of, it's hard. Obviously, it's not as tangible and, and concrete in terms of this is the condition. So is it very much a process of elimination as well with psychiatry in terms of the co-occurring? Because quite often, when you medicate for ADHD, sometimes that's when you see autism come through. I mean, that was the case with my daughter, for instance. So would you say a lot of that, there's a bit of testing and measuring to kind of identify what's going on?
I'm afraid there is, yes. There is a bit of that.
Yeah, there has to be, right? It'd be great to hear from any other psychiatrists around that, if anyone wants to.
I saw Maita smiling.
Yeah, Maita?
Is there anything you want to add there, Maita?
Oh, you're on mute.
Yeah. You know what? I'm just struggling with the lights, and I'm so sorry because I'm trying to put my camera a bit brighter, but it's anyway. Sorry about that. You know what? It's very interesting because I worked in ADHD for over 20 years, and 20 years ago, when I was diagnosing someone with ADHD, a young person, then and I've been working more specifically in psychoeducation. So what I've done is like psychoeducation with families of children with ADHD, ADD. And when I was working with them and the families, then it turned out that then the parents or someone in the family would turn up saying, listen, I think I have ADHD, right? And now 20 years later, it's been kind of the opposite, okay? So sometimes like the patients that we they refer to us come with the, I have the message, this young person has a father or mother that recently diagnosed with ADHD, ADD. So it's kind of like, it's been a massive change. I think for the good, because
Absolutely, yeah.
but previously it was just like really fascinating hearing parents when we were delivering the sessions and when we were disclosing and telling things about ADHD, and some of the parents would say, listen, I've been diagnosed with depression all my life, and then all of a sudden I realized it's not just depression, I don't have depression, I have ADHD. So it was very revealing for parents, right? But it's fantastic to see that the thing has somehow flipped to the other side, and we can then identify children, or it can be like the two ways to identify ADHD, ADD, right?
But that's a really good point.
I mean, and this is what I think I was kind of getting at in a way, because I think a lot of people would be fascinated by A, that connection, or B, what it's almost a chicken before the egg situation. So is someone who has a certain kind of depression, is that an offspring of their ADHD which has not been diagnosed? And therefore, because they have had that untreated ADHD, they might then engage in some kind of substance abuse to calm the thoughts and to help with some of the symptoms of ADHD, and therefore the ADHD will be the primary factor. Is that something you sometimes find?
Yes, sometimes that is the case, but so I think I forget the expression that you used, Stephanie, but it generally is sometimes a game of trying things out and figuring it out, because most stimulants that you use in ADHD have some antidepressant properties, and they are a recognized second line strategy in someone who has responded to an antidepressant, but they still have residual symptoms. So you could conclude that someone, or someone could conclude that they always had ADHD and that's all there was, and not that they had also depression, for example. If you start a stimulant too soon.
Okay. Well, it's Amber, sorry.
Again, I'll be really brief, but I think we have to be really careful not to move from it's only this or it's only
that. Yeah.
I think sometimes even in psychiatry, having worked as a psychiatrist for 20 years, I can see that that's happened over time. ADHD, often the adults with ADHD, if you look at an 18-year-old onwards, 50% overlap with anxiety and depression. So I think as a psychiatrist, when we're following DSM-5, we're thinking about what else could explain some of these symptoms, but also what is the developmental picture here? So when did these symptoms start? Were they before the age of 12? Are they pervasive? What's the cost of the symptoms? All those kind of things. I think taking a really careful history. And I've had patients, kind of young adult patients, where we've actually, we've had a very honest conversation with each other. We've said, look, there's ADHD here. There's also some anxiety. This is what could happen if we treat this one first versus this one.
Yeah.
And sometimes I agree with Filippo, sometimes we do treat if it's moderate to severe depression, there's risk, then actually we have to look as psychiatrists and with the patient together co-construct what's the highest level of priority here. Is it managing the risk? Is it kind of, because I've had some patients who are really in difficult places, and it could be like, you're saying chicken or egg, which one came first, and it's hard to know sometimes, right? But if you're neurodivergent, then the soil in itself, makes you more susceptible, more highly sensitive. Think about kind of temperament and thinking style and rejection sensitivity, dysphoria, all those things. more likely to experience trauma as well, So I do, and process those experiences differently as well from a neurotypical brain. Then it really is, the formulation is really, really key here. And then explaining that to patients. So what, again, it's going back to what's the story here, not just the diagnosis, what's the story for the patient, and what do we think is going to best benefit them as a psychiatrist?
Is there anything you'd like to add?
No, if anyone else has anything.
Yeah, I think we have to accept that almost by default, most patients with ADHD will have some comorbid or coexisting other psychiatric condition. I think we need to accept that, and therefore it requires expertise to look for those other conditions and recognize them and treat them appropriately. I think the one more thing that, just to add to complexity of all these, is that a lot of patients with ADHD would present with some traits of autism, if not autism as well. And majority of patients with autism will have symptoms of ADHD, if not ADHD as such. So, if we also during assessments need to, we do screen for presence of autism, and then it need to be assessed. So it's and then of course, if you got autism and ADHD together, that's another ball game. The presentation is also quite much more complex, and they've got again more anxiety-like presentation, and more dysphoria, and maybe more withdrawal and kind of emotional numbness or alexithymia, and they could be constructed or understood as depression, but it could just very well be just an autism. So, again, I think it's very much tinkering, and I think it's very much like you say, probing this and probing that, and testing the hypothesis as we go through assessment. We create hypotheses and we test them, and we see what works, what doesn't, where patients fit in, and that just reflects how the DSM construct is imperfect. Yeah. And we try to fit something in, there's something that is round in the square hole. That's what it is. A lot of times.
As you say, it's always something which is a process, and it's trying to perfect that process as much as possible, or improve it as much as possible. We are going to move on one question there. I think we're going to go to a question which I think is very important in many ways. I think a lot of people would like to know, with your experience with your clients or patients with ADHD, how effective is the medication in terms of daily functioning? And as we're talking mainly about the workplace today, in the workplace, is there anyone who'd like to answer that question?
So I would say that, in fact, I would say this to patients, that the medications are very, very effective. One of the advantages compared to medications for in other conditions is that the idea with these medications, the stimulant medications, is that they act straight away. They cover a few hours over the course of the day, and then they have to be out of your system as the day comes to an end, so that they won't interfere with sleep. Most of the medication has to be out of your system. And so they fit very, very well a disorder where you want to see results quickly, which is not what you see in depression, for example, where it is well recognized that although some effect you might be able to detect with sophisticated tests from day one, just one antidepressant tablet will make very subtle changes to things like your pre-attentive bias for things. Actually, you start to feel better in a small, by way of small incremental changes over 2, 3, 4, 5, 6 weeks. And so medication for ADHD have that advantage instead. You see the benefits straight away. However, it goes with what we said at the very start, that that this is a disorder where the manifestations will follow the ups and downs of pressure and circumstances and hormonal changes and physical health and so on. You have to accept that medications would not be the be all and end all. In fact, they are just the way of giving yourself a stable platform on which you can make changes that then will enable you to manage these problems better and better, with psychological therapy or coaching and all the things that we were saying before. Because otherwise, you might find that you're very well on a certain dose of the medication, and then when the game gets tough, when there is added pressure, you see the problems re-emerging, and then your only answer to that will be, if you haven't done your work of understanding the mechanisms for those problems, your only answer will be, I need more medication. I need to escalate the medication, and or try a different medication that is more effective. So it's a really crucial, and I think a non-fact, but not by me, because I can't remember if it's 2 or 3 years. But the median duration of treatment with medication is 2 or 3 years. So the median is the point that splits a population in two. So 50% will stop medication after 2 or 3 years. Of course, their ADHD hasn't stopped, except there might be some cases in which it was misdiagnosed. But for the majority, it's about that gap between being on medication and being off medication that has shrunk over those 2 or 3 years. And at some point, they decide that they don't want to make the effort, coming to see me and following the vagaries of availability of medication and having to get the prescription and all the other things.
It's absolutely fascinating, because I do think, as you say, you mentioned the fast actingness of the ADHD medication. You agree with this. There's so many people who have that story of it, their well-being changed once they've started the medication for ADHD.
Yeah, it can be completely transformational. I share when my daughter first went on it, when she was only 5, but she couldn't really have a conversation with her. She was very hyperactive, impulsive, quite dangerous, quite reckless, and she couldn't learn. She couldn't sit down and read. And then literally, I remember it so well. She took it within 25, 30 minutes, she's talking to me, sitting down at the table and actually kind of reading the book. I'm like, wow, that was, yeah. And, and I never forget when she was about 9, she turned around, she said to me, "Mum, thank you for medicating me. I wouldn't have been able to learn." And she wants to be a lawyer. She's at college now studying law, psychology and business. It was transformational. So yeah, that's the personal experience I've had.
Is there anything anyone else would like to Maita?
Yeah, just what you're saying, Steph, is absolutely what we sometimes, so the changes in presentation is going to depend on the patient. Not all the patients are benefiting as much as your daughter, but sometimes it's just as you say, transformative. You can transform lives, yeah. And in my experience, especially when other factors are well controlled, like when families have the support, when the child has support in school, then is when medication is just making them blossom, right? Because the other factors have been well controlled, right? So the only factors is the medication but then again, how important it is for the medication to be absolutely tailored to the person, so that the person is benefiting the most, but without having side effects. Sometimes when I read these comments of people online talking about side effects and how bad they were feeling with the medication, and then I sometimes wonder who was managing the medication. And because I've seen some people just putting the medication, just leaving the patient without much follow-up. So, and I wonder, because in my experience, this is usually not the case. The case is you might or might not benefit as much, okay? But in any case, you shouldn't have side effects. So it's about, balancing pros and cons, right?
Absolutely. Sorry, Amber, did you have something to add there?
Yeah, I think, what we know about treatment in children and treatment in adults, it is a bit different. So I think just really important, and with adults, because we do see, more coexisting challenges, because you've lived with ADHD for a long period of your life. Some of our adults have lived half of their life with ADHD, right? And they've had to deal with difficult family situations, friendship rejections. There's been lots and lots of layers to them, different parts to them, which in a way have been neglected, when we think about it. And that's why I think that, medication does have a huge, it's really important, and it can be a game changer for so many adults with ADHD. But I think the bit to really add is, and what we're learning about, is that holistic bit. So if you're in fight or flight, if you've got anxiety, the medication may or may not be that effective. And therefore, it's really important to look at your sleep and look at kind of, your nutrition, and look at your social connections and your work environment. Is it the right work environment for you? These are kind of often things that people with ADHD adults, they start thinking, actually, if I can't change this, or if I can't change my response to this, then actually maybe I'll try something else that's more suited to the way that I'm wired up and the way that I'm built. So I think, that education piece again is really key alongside the medication.
100%. I think something you always say is the pills don't give
Well,
skills.
that's David Gowak Adka. Yeah, the pill don't give skills.
But
Pills don't give skills. Yeah,
it is absolutely true. As helpful as the medication can be, there has to be that follow-up support, and I think that's where coaching can come in,
and therapy
and therapy.
Yes.
With that, as psychiatrists, where does the roles that both play come in terms of the coaching and the therapy? What are your recommendations for them? Would anyone like to come in on that?
I just like, so you're asking about the therapy and coaching.
Yes, exactly. So in addition to the medication.
Yeah.
Yeah.
I think it's very important. In my experience, though, I must say that unmedicated patients with ADHD do not really like CBT very much. And I think it's too regimented and it's too homework-like. And I think they just majority of them do not like it. I think something like DBT for emotional dysregulation can be very useful, I think, and coaching as a more pragmatic approach to finding strategies is certainly preferred. I think some mindfulness, I think some patients really like that. And something like a meditation in movement, maybe, something like yoga, maybe Tai Chi, maybe not strictly a therapy, but I think that's kind of useful. And that's my so certainly I recommend the therapy in one or the other form, but I think it's absolutely important as a holistic approach and not rely on medication alone. Yeah,
absolutely. It's taking that holistic approach and taking in all avenues. Maita, did you have something to add there?
Yeah, I can't. Yeah. So yeah, basically, one of the things that I've seen or noticed is in so many people, even young people, just to rely too much on medication. And sometimes it's like they feel so much helped with the medication that they think medication can be everything. So I kind of understand where they come from, okay? But I always insist it's not just medication. It's about getting to know yourself, getting the help. I agree coaching might be much more effective in a way, or accepted, than some kind of type of therapy that can be more considered as a structured and boring, or but then getting to know yourself and getting where things come from is so important. And I think one of the problems is if you rely too much on medication and then just ignore the signals and the things around you. So yeah, totally, 100%. Yeah, ADHD is not just medication, is more than that, far more than that.
Absolutely. And Stephanie, obviously you have a relationship with
psychiatrists
here, so that relationship between coaching and
psychiatry. It's so important, particularly for clients, titrating as well, because we can see them in coaching, we can see the difference. we can also kind of, a lot of ADHDs are blind to their own kind of patterns. So, but we can help them get those down so they can report them back to the psychiatrist as well. I've been noticing, yeah. So it's really helpful in that stage in particular when they're starting to, you know, when they're in titration, for instance. But yeah, we're always kind of working together. I've got some of our referral partner psychiatrists. We can, you know, they share kind of some of the reports on our common clients, so we can see what they're going through as well. So we're just more on the same page, so we can, yeah, again, taking more of that holistic approach.
Absolutely. And is there anything else anyone would like to add? We're coming to the end of
this has been
interview.
amazing.
It's been absolutely amazing. Thank you so much, guys, for joining us this evening.
To have all your expertise.
It's been absolutely wonderful.
Yeah,
thank you.
And we'll obviously we'll send you the recordings as well, and then I know Maita, if any you want to share, for instance, any of the psychoeducation programs that you're also been doing, I know for parents with kids with ADHD.
Yeah,
so
thank you, Steph.
Yeah, send that link to us and we'll get that across the platforms as well, because ACs need all the support that they can get.
Absolutely.
And you guys definitely know what you're talking about, and it's a pleasure to partner with you. So thank you so much.
Thank you so much, everyone.
Thank you.
Thank you.
Happy
Thank you.
Halloween.
Really appreciate it. Thank you very much.
Yeah, we're taking a break now. So we've just got 20-minute break. So please go and coffee, answer your door to the trick-or-treaters, and we'll see you at 6:20.
Thanks.
Thank you.
Cheers. Thank you.
Bye.